Okay, my name is Eric Johnson. I'm a professor of surgery at the Cleveland Clinic, Lerner College of Medicine of Case Western Reserve University, um, and a member of the American Society of Colorectal Surgeons as well as SAGES. And I'm thankful to have been given the opportunity to participate in this joint symposium to discuss this interesting topic. Oh crab, you're in, but you find cancer instead of diverticulitis. I can guarantee everybody in the room has been there. And it's something worthy of discussion. I have no disclosures other than the fact that this lecture is all based on personal experience and opinion. You're not going to find a scientific manuscript or randomized controlled trial that tells you how to manage things in this scenario. This is all about having been there and coming up with a plan to manage these patients who can be quite challenging. So this slide, for those of you that don't know me, I'm retired military, and anybody who's spent time in the military has probably spent time doing this. And I say this tongue in cheek, I miss the military because it taught important life lessons like don't be dumb or you will mop the rain. And the only reason I put this up there is if you make mistakes in the management of these patients, or if you do things in the wrong order, you may find yourself outside mopping the rain. So I think the best way to deal with this is to present cases. And so I'll give you a case of a 62-year-old male who presented to the emergency department with 3 days of left lower quadrant abdominal pain. He was febrile, he had a leukocytosis, he was tender palpation in the left lower quadrant on abdominal exam with localized peritoneal signs, but no overt signs of peritonitis. And he had never had colonoscopy. And the CAT scan here was what we saw. And so as we scroll down through the CAT scan, you know, the upper abdomen, other than a cyst in the spleen, is fairly normal. He's not particularly obese. But as we scroll down into the lower abdomen, you'll see a pretty significant inflammatory process involving the sigmoid colon. And this was read as diverticulitis with a contained perforation. So he was admitted. He came in late in the evening to the middle of the night. He was admitted. He was placed on bowel rest with hydration and intravenous antibiotics. And you know, his condition improved pretty remarkably. So by the next day, he was feeling much better. And ultimately, he was discharged to home to complete a course of oral antibiotics without patient follow-up. But I would say it's important to know what you're looking at, right? So you can look at a CAT scan, and despite our radiology colleagues may say about it, I think there are certainly warning signs on a CAT scan. And you can see in the pane in the left, this gentleman was being interviewed about a lottery winner in New Jersey and gave them a name that the reporter and the news station clearly did not realize, you know, in terms of what they were looking at. So, and they kind of ended up looking foolish. And so this gentleman came back to see me in clinic. He had continued mild symptoms. And so we repeated a CT scan on him, and you can see this. And so, you know, our initial plan of performing a colonoscopy 6 weeks after symptoms resolved was changed. You can actually see some signs of maybe low-grade obstruction in the colon on that CT scan, and certainly with him feeling somewhat better but not completely better, those signs are concerning. And so we ended up operating on him. We attempted to bowel prep him, which he did not tolerate particularly well. When he came in, he had overt signs of a large bowel obstruction, and he ended up getting a Hartmann's procedure with later colostomy closure. And he did, in fact, have a colon cancer with a contained perforation. Another case that I saw, so a 72-year-old female who presented initially in the month of November of 2019 with a diverticular abscess She was treated with percutaneous drainage and antibiotics for 2 rounds, actually. She had a drain, it came out, and then was drained again. Had no improvement in her symptoms despite being discharged from the hospital. She had never had a colonoscopy, and ultimately she was readmitted late in December, so a month and a half after the time of initial presentation, with continued symptoms. And I'll show you the imaging. This is her initial imaging from the initial presentation in November. So some redundancy to the left lobe of the liver, relatively thin lady. With, as we approach the left lower quadrant, with a significant inflammatory process in the left lower quadrant, obvious contained perforation with abscess formation, and that abscess was drained twice. And then on the right side of the screen, you can see that she's actually lost some weight, and you can see the difference in the amount of abdominal fat on the right, with some weight loss and a persistent inflammatory process in the pelvis that looks quite involved. There's an air fluid level in the bladder. This is a concerning appearance. And when I was consulted, the initial plan was to perform some type of bailout operation on this lady and not even resect the primary. The discussion was to just go in and drain things and get out. And I didn't like that. I ended up doing an open laparotomy on her, was able to resect the mass and do an anastomosis, but did a diverting loop ileostomy. Her pathology did reveal a colon cancer with lymph node positivity and contained perforation. There was some invasion of adjacent tissue that was resected en bloc, and she ultimately went on to have some chemotherapy and later stoma closure. So talk about how to approach these patients. So there really is a stepwise approach to this scenario, and I would emphasize your first shot is the patient's best shot. And so it's best to make a good plan, execute that plan, and do as much as you can right off the bat, in my opinion. And so number one, prepare and predict what you're dealing with. So if you have imaging findings that look like maybe there's a little more than diverticulitis going on there, there's big mass effect, there's fistulization, there's obstruction, etc. Not saying that it couldn't just be diverticulitis, but those are suspicious findings. And so you have to consider the presence of a colon cancer or other type of neoplasm for that matter. In the patient who hasn't had a recent colonoscopy and is in an older age group, you certainly have to be suspicious, and you can even check a CEA level on some of these patients. And if it's elevated without other obvious causes, obviously one should be suspicious about the presence of a colon cancer. Assess and consult. So on imaging, you can assess adjacent organ involvement. You can even get MRI, which is particularly useful in the pelvis. If there's a suggestion of adjacent organ involvement, you may want to involve your urologic, GYN, oncology, or vascular colleagues before you take the patient to the OR for preoperative planning. Can you perform a bowel prep on the patient? And so a lot of times we in the acute setting, we eliminate the idea of a prep from our mind, but many of these patients, especially when we're in the setting of kind of smoldering acute disease, they can tolerate a gentle or slow bowel prep. And if the colon is prepped, you have more options in the OR. Be ready to open. So there's nothing wrong at all with minimally invasive approaches in these patients. In fact, the first case I showed you, I did with minimally invasive surgery. The second, I did not. And if you're good with minimally invasive approaches, either laparoscopic or robotic, go for it. But always be ready to open. Another thing that I think is underrated is the hand-assisted technique. And so if you're somebody who's got experience with hand-assisted laparoscopy, it's quite helpful in these cases where there's bulky disease. You have the ability to finger fracture where it's appropriate. You can use the hand as an atraumatic retractor, and it's very helpful. Interoperative consultation always has to be on your mind. Don't hesitate. If you're concerned about involvement of the ureter, if you can't locate a ureter, if there's bladder or uterus involvement, don't be afraid to call a colleague into the OR. If you haven't put stents in ahead of time, which is certainly something you should consider doing in these cases, you can always put stents in the middle of the case, and they can be helpful. There are adjuncts like fluorescence imaging. If you have that equipment in your hospital, they've got stents where you can use this. You can inject the stents with fluorescence material, and you can sometimes be helped with those adjuncts. Unblock resection. So again, this is not the time to be skimpy with what you remove. I know very often with acute, quote, diverticulitis cases, people want to do sleeve resections of the colon, really do a minimal resection so that you don't put adjacent structures at risk. But if you believe you've encountered a cancer, that's not appropriate. And so if it's stuck or invaded, it really probably should go. You have to ask yourself that question. Is it just stuck? Is this just desmoplastic reaction? Can you finger fracture around this, or is there true invasion? And certainly when in doubt, you want to resect adjacent tissues, unblock with the primary specimen to achieve an R0 resection. So specifically to address R0 resection, as I said, now is not the time to take the easy route. You need to remove all involved tissues. You need to do an appropriate lymphadenectomy so the patient can be appropriately staged and treated. And you know, these things are very important. And so I would encourage you to perform a high ligation of the inferior mesenteric artery. Certainly that is debatable based on some literature, but I think the vast majority of surgeons dealing with these patients on a regular basis do perform a high ligation, taking the IMA flush with the aorta. You're certainly assured of getting an excellent lymphadenectomy by using that technique. Plus, it sometimes gets you away from inflamed into non-inflamed tissues. And, you know, when you approach the ureter, the medial to lateral approach, even using open technique, can be quite useful to locate the left ureter if you can't easily approach things from lateral to medial. You need to assess for metastases. And so solid organ metastases are sometimes the most obvious. If you see a liver lesion, it's wise to biopsy it. You're already there, you've got access, and you'll save the patient a second step that the oncologist is certainly going to want to perform. Take a good look around and look everywhere for signs of metastases. If there's free fluid, you can send that for cytology. If there are peritoneal mets, again, don't write the patient off. There's definitely a role for future cytoreduction and HIPEC in the appropriate setting. It's important to make note of all of these findings and note them specifically in the op note, because if you are going to refer the patient for further surgery or to medical oncology, these findings are all helpful. And so important steps to take. I think it's important to set the table for the next person, whether that's medical and radiation oncology or another surgeon. And so if there's areas where you have tissue where it's stuck and you can't resect everything, it's important to place clips in those areas. That's a target for the radiation oncologist, and certainly in the pelvis, radiation is appropriate. The use of seprafilm is controversial, but certainly seprafilm around a stoma can make stoma takedown easier, and seprafilm laid in certain areas away from anastomoses can make reoperative surgery easier and potentially reduce the risk of future bowel obstructions or certainly bowel obstructions that require surgery. If you're leaving a rectal stump with thoughts of future anastomosis, you don't necessarily have to tag it. In fact, I don't tag them when I know I'm going to come back, but certainly if you're going to send it on to another surgeon, I think it's reasonable to tag that rectal stump with long proline sutures so that it's easy to find. And, you know, I think there are scenarios where maybe we run into cases that are too complex for our current practice. If these are things that you don't see every day or all the time, and you feel like you're in and the case is too complex, I don't really like this option, but you can be prepared to bail out and transfer the patient. I think if you're going to transfer the patient, you want to transfer them to another surgeon. You want to do that immediately so that that surgeon can plan for early reintervention if it's appropriate. So in conclusion, I think it's important to assess the patient prior to surgery and assume the worst so that you're ready in the OR. Understand your own capabilities and your hospital's capabilities as well as resources so you know what you have available depending on what you run into in the OR. I think it's always important to keep in mind that the first shot is the patient's best shot, and asking for help is an okay thing to do. So hopefully this lecture was helpful and everybody got something out of it.